Hi, it's Dr. Eric Balcavage, and we're back for another edition of Thyroid Thursday. And today I want to follow up on last week's Thyroid Thursday, where I talked about thyroidtoxicosis in a patient of mine who was told she had thyroidtoxicosis and because her TSH level was really low, and her endocrinologist decided to reduce the dose and termed her having thyroidtoxicosis. Now, we said that thyroidtoxicosis is an excessive amount of thyroid hormone, and most medical doctors and endocrinologists look at that or evaluate that by looking at a TSH level, and the TSH will be really low. And in her case, when she went back to see her endocrinologist, her TSH level was 0.052, which is really low. The typical lab range for TSH in a medical practice is somewhere between 0.4 and 4.6. In functional medicine, we look at a range closer to 1 to 3 as more of an optimal range. But anyway, I said I would talk about her case and kind of show you what was going on with her and kind of lay out what's going on. And I have her permission to kind of go through this. But this woman has been diagnosed with hypothyroidism. She's had it for a number of years, and she's been on Synthroid for a number of years. And she is still symptomatic. So she had her TSH levels done sometime in July, met with her endocrinologist in September, and because she was still symptomatic, I guess she may have suggested to her medical doctor or the endocrinologist that maybe a combination therapy may help her out more, because even though her TSH was 0.58, which would be normal by medical standards, she was still symptomatic. And as we've talked about on many of these Thyroid Thursday podcasts, hypothyroid symptoms occur because of what's happening at the cellular level. And TSH really just represents the saturation of T3 at the pituitary gland. And as I've said over and over, the pituitary gland acts differently or is regulated differently than the rest of the cells of the body. So your TSH level could be totally within normal range, and yet you could still be hypothyroid at a cellular level because the thyroid hormone isn't getting into the tissues and into the cells. So this was the value in July. Sometime in September, they switched her from Synthroid to Nature-Throid to see if that might help her get rid of her symptoms. After a few weeks of working with the Nature-Throid, she consulted my office. She still had lots of symptomatology, and so I ran a comprehensive lab metabolic panel, but here's just the thyroid portion of what we ran, okay? And we ran some other tests as well, but I just want to point out what her thyroid levels were. So between beginning of September and the end of September, when these labs were run, her TSH actually got a little bit lower. Now, why did that happen? Well, again, she's taking Nature-Throid, which is a combination of T4 and T3. It's a glandular product, so it's got all the thyroid hormones in it, but she got a little bit more T3 into that system. So essentially what she's getting is T4, which can get converted very easily in the pituitary gland, and T3, which doesn't need any conversion at all. It's ready to go. So what happened from the time she got the Nature-Throid till I ran the blood work is she was just super saturating that pituitary gland even more. Didn't really have a change in symptoms with the Nature-Throid, but her TSH level dropped. So if we take a look at the rest of her thyroid panel, her T4 is 8.2, T3 122. Essentially, all the values except T3 uptake are within normal, optimal range. T3 uptake's out of the optimal range, but would still be well within the lab standards. The only thing that's of note here is that at the onset, this would look good. She would almost look hyperthyroid because of how low that is, or her doctor may say she was thyroidtoxicotic then, but I calculated her T3 divided by her reverse T3. And when this value, hers was 8.4, but when this value is less than 10, that indicates to us that the person has more reverse T3 being made in comparison to her T3. And so it's a ratio. Anything less than 10, you're probably getting more reverse T3 or inactive T3 compared to your T3, and that reverse T3 can actually compete for the binding sites. So we use this as a good indicator of cellular hypothyroidism. Now, between September and November, I ran some additional lab testing. We wanted to find out why she would have hypothyroid symptoms even though her TSH level was 0.16. If you've heard me talk before, the body really doesn't make too many mistakes. One of the biggest causes of cellular hypothyroidism is something called the cell danger response. So when there's stress on the body and there's the mitochondria, the little engines of your cells, take that as a stress response, and it triggers this cell danger response. And part of the cell danger response is to decrease the health of the cell to try and kill the threat. If there was a virus or bacteria within the cell, you would make the cell more insulin resistant, you would decrease thyroid transport, you'd slow metabolism down so that you can kill the threat or kill the organism. What we definitely found out, but when we got the results back in October, was that the patient actually had a pretty significant bacterial infection, and that bacterial infection is part of her cell danger response. So what did we do? We started her on a dietary program and a supplemental program to start working on addressing that dysbiosis, that bacterial infection. And so after 2 weeks of starting that process, she's already starting to see some change and improvement of her hypothyroid symptoms, which is great for a person who's been struggling for years with hypothyroid symptoms, and then within 2 weeks of starting some care, she's already starting to improve. Now, last week, she went back to the endocrinologist, they reran her labs, and now her TSH is 0.052, which led her doctor to say that she had thyroidtoxicosis. She had an excessive amount of thyroid hormone. Now what happened? And you can see that her doctor didn't run nearly as expansive of a thyroid panel. All he ran was TSH, T3, and free T4. And so when we take a look at what's going on here, yes, her TSH dropped even more significantly. Why? Well, the doctor's prescribing thyroid hormone. It's T4 and T3, so it's super saturating the pituitary gland. But she also may be getting healthier as a result of reducing the stress on the system, starting to work on killing the infection. And so the combination of those two things, she does not need the level of thyroid support that she had before. So her doctor cut this dosage down. Now what we don't know is what this new ratio is, the T3 to reverse T3 ratio. We don't know what that is because that value was not run. Her free T4 values actually dropped. Now, why would her free T4 levels drop if she's feeling better? Probably because when you reduce the cell danger response, you increase the ability to transport thyroid hormone into the cell, which should make the blood value of free T4 drop. So in this situation, her doctor really did the right thing. She didn't need as much of that thyroid hormone as she was getting. So the good part is we reduced that. It would have been really nice to see what the reverse T3 value was, see if it increased or decreased from 14.6. But with the fact that she's actually feeling better within just 2 weeks of doing some of the care that I've recommended, my guess is that we're getting more thyroid hormone into the cell. Not because she's taking a glandular product necessarily, but because we're reducing the cell danger response, we're reducing the infection, and we're increasing the ability to transport more thyroid hormone into the cell. So that's this case, and you can see a couple things to point out. Most medical doctors and endocrinologists run a very limited panel when they look at blood work, but really we need to take a look at all of these values, and especially we want to see what reverse T3 is, because if somebody's giving you thyroid hormone, it doesn't necessarily convert to an active form, get into the cell, and stimulate metabolism. The cell danger response will work against that. So anytime you are getting thyroid hormone support, whether it's Synthroid, Nature-Throid, Cytomel, any of those, you want to make sure you ask for a reverse T3 along with a very comprehensive panel. You want T4, T3, T3 uptake, free T4, free T3, reverse T3. You want all of those values. Your doctor may say they don't need it because the only thing they're worried about is TSH, But TSH does not give you a good indication of what's happening at the peripheral cellular level. It only indicates what's happening at the pituitary gland. And remember, the pituitary gland reacts differently. It's regulated differently than the rest of the cells of the body. So you could have a low TSH like this woman has, and yet still have plenty of hypothyroid symptoms because this pituitary gland is getting saturated, but the cell danger response is decreasing transport into the cells at the periphery and decreasing conversion. And oftentimes what I see with people who are on thyroid hormones is that at the higher the dose gets to lower the TSH, the higher the reverse T3 gets, and the lower this ratio gets. And if this value goes up and this ratio goes down, then the person is having cellular hypothyroidism. They're converting more of that endogenous thyroid hormone or exogenous thyroid hormone to reverse T3 than they are converting it to an active T3. So hopefully that helps. If you have any questions, you can always email me at the office or put a comment below the video and I'll answer it maybe on one of the future Thyroid Thursdays. Hopefully that helps. Look forward to another one of these next Thursday.